very good evening, everybody. I'm Dr. Roshli from the medical team of USV, and it gives me immense pleasure to welcome you all to this one more episode of CME India, where today we are going to discuss about hepatitis B, what is new, and what could be life-saving. And without further ado, I would like to welcome the man behind this initiative, none other than Dr. N.K. Singh, sir. I don't think sir needs any introduction. So thank you so much for this great initiative, sir. I welcome you on behalf of the entire team and further to you for the proceedings.
Yeah, thank you, Arfil. So I think welcome viewers, welcome all our moderators and our esteemed speaker today. This will be a very important session today. That what he knew, what could be life saying in hepatitis B. Whatever the discipline of the internal medicine is, I think we all are concerned with that because we are living in an era where early intervention, precision antivirals, and timely referral can change survival. With that, can you display the next one? Yeah, next, Vishal, next. Vishal, can you go to there? So, welcome Dr. Mohsin Aslam. He is the one of our moderator today. He is a consultant physician, clinical scientist at the Asian Institute of Gastroenterology, Hyderabad. He is the executive committee member, RSSDI Telangana chapter, joint secretary of so many Telangana chapter hypertension. And I think we are well, our CME India people know him very well. He has got so many awards. So welcome. Next. I also welcome Dr. Narayan Agarwal. He is the MD DM Gastro, DNB Gastro, and senior consultant at the and director and head the Sai Hospital Siliguri. He has a huge experience in gastroenterology and worked as an expert and participated in research work and so many things. So welcome, sir. Next.
Thank you, sir. Thank you.
Yeah, and I also have great pleasure in welcoming Dr. Sanjay Shah from the Uttarakhand, from the basically he is at the Haridwar now. He is a lifestyle consultant physician, Director Swami Ram Prakash Charitable Hospital, Haridwar, Medical Director of the Swami Vivekanand Health Mission Society, past Chairman of the Research Society for a Study of Diabetes in India at Uttarakhand, and he has also worked at so many hospitals and doing a great service to our people. So with that, uh, I request Dr.
Thank
Mohsin
you.
to introduce our esteemed speaker today. So can you display the CV of Dr. Kulkarni?
Yeah, good evening, everybody.
Yeah,
Yeah,
yeah.
good.
So, for today's discussion on hepatitis B update, I welcome Dr. Anand Kulkarni, sir. He's a senior consultant and director of critical care hepatology at AIG Hyderabad. He has over 150 PubMed Index publication and served as a reviewer and editorial board member for numerous national and international journals. He has received SK Naik Best Researcher Award by Indian Society of Gastroenterology in 2025. He has received Early Career Investigator Award from AASLD for the year 2022. He is a member of many liver associations like AASLD Liver Transplant, member of AASLD Portal Hypertension, and member of Global NASH Council for ALD. And he is our go-to-go person for any liver-related issues at AIG. Over to you, sir.
Thank you so much for the kind introduction, Mohsin. Thank you, NK Singh sir. Thank you, CME India, for having me here. I'll try to brief about hepatitis B, what is new and what actually has. There is some research which has been going on. The treatment aspect, which has been simplified in the recent years. I'll try to touch upon those things. Apologies for the delay. So I will be
Yeah.
just touching upon why does HPV matter in 2026? What is the new nomenclature which has been modified? Practical monitoring and stopping rules, functional cure, where do we stand? What are the newer molecules which are in pipeline, which probably will get approved and in a year or two will be able to completely cure hepatitis B. Special situations which as clinician especially should know. I'll touch briefly upon those things as well. So in India, the prevalence is around 0.95%. The prevalence is pretty high in Andhra and Telangana, where I live. It's very, very high in our areas. But in the northern states, it's somewhere a little on the lower side. In India, especially, the prevalence is very high in men. It is 1.16% compared to women of 0.75%. Higher in rural areas where we need robust screening measures. Just a screening on hepatitis B spot testing is sufficient enough sometimes, but if possible, if you can do a clear method, that will be more beneficial. Then urban areas, yes, definitely there is high in rural and then compared to urban areas. Tribal areas, that is where we require a focused, projects to identify hepatitis B. The prevalence is as high as 16%. Probably Dr. Agrawal can agree with me that in tribal areas, the prevalence is significantly higher.
Yeah.
If you see the reason why we are struggling is the lack of vaccination. Taiwan, they have eradicated hepatitis B. The reason being they have effective vaccination measures. They just go to every nook and corner of the country. They identify hepatitis B and they treat them irrespective of the DNA load. What their measures is very simple. In fact, Chinese guidelines has made it even more simplified. HPSCG positive, treat the patient because the prevalence of HCC in those countries is pretty high. Whether this is viable in India is little not. I'm not sure about that. I'm not an expert about that. But some experts in India do believe that HPCG positivity is sufficient enough to start the treatment for hepatitis B. But we must learn from Taiwan that improved vaccination can prevent spread of hepatitis B, and we may be able to eradicate hepatitis B. This I have taken from the WHO, where they say that 9 out of 10 men living with hepatitis B still don't know it. 100 million women across the world do not know that they are having hepatitis B. 42 million children don't know they are living with viral hepatitis. In Southeast Asia, 97% of men and women living with hepatitis still do not know it. In fact, hepatitis B and C kill more patients, more individuals than HIV, AIDS, malaria, and tuberculosis. And they are responsible for 2/3 of the liver cancer deaths. India and China will contribute to at least more than 2/3 of the liver cancer deaths worldwide and 50% of the liver related mortality worldwide. We come of the literature on the natural history. We know that vertical transmission is very common, mother to child transmission, and these patients go on to develop chronicity. It's very the most often they develop chronicity. Up to 5 years, the chronicity is still on the higher side. After some age, in the adult population, the chronicity goes down to less than 5%. Once the patient has got this infection, the liver inflammation and fibrosis, the chance of developing HCC, even in the absence of advanced cirrhosis, remains around 5 to 15% in the lifespan, annually around 0.2 to 0.5%. In cirrhosis, liver if the patient gets infected and if he has inflammation and fibrosis, 30% of them go on to develop cirrhosis. The chance of developing acute reactivation has not been assessed worldwide, but still we do see some patients with acute hepatitis B where they present with acute liver failure where the chance is 1%. According to me, we tend to start the patients on acute hepatitis B as well, even if the bilirubin is more than 5 and INR is more than 1.5. These patients will tend to require liver transplant as a definitive measure later on if they do not respond to any of the medical therapy. And for liver cancer, the best treatment would always be transplant or resection or ablation. The phases which have been classified now is two: E antigen positive, E antigen negative. They made it as infection and hepatitis. Infection where the viral load is high, the patient does not have inflammation, so their ALT is normal. If you see here, the ALT is normal, but the viral load is high, but there is no liver disease. So this is infection. Hepatitis, when there is the virus load is high, there is inflammation, liver disease is moderate to severe, this patient will require treatment. In E negative, again similarly, infection and chronic hepatitis B. Infection when there is some viremia less than 2000, but there is no other effect. These previously were said to not require any treatment, but WHO has changed the guidelines recently. In phase 4, that is hepatitis B, elevated DNA, elevated enzymes, there is hepatitis, there is inflammation. These patients require again treatment. The patient has a resolution, it is very rare, but seroconversion is well known in hepatitis B. When this can occur and these patients do not require any treatment. Monitor patients with infection and treat hepatitis was the long-standing notion which we used to follow according to EASL guidelines. But there are some changes which have been suggested by worldwide guidelines, especially the WHO. So this is how the disease progresses over the years. It can be in chronic infection. Initially, they develop E antigen. Then they have hepatitis. If you find a patient over here, this patient needs treatment. But then if you do not treat, the natural history is to progress towards chronic HBe Ag negative chronic hepatitis B. Normal levels of ALT has been challenged several times, but the West now believes that 19 international units per liter for women and 30 for men is normal. Anything more than that is considered abnormal for ALT levels. Why do I say about ALT? I will be just talking about these three aspects, then I will be touching upon the treatment aspect. For our population in India, INASL guidelines is 40 units per liter is normal. So for us, even today, we consider 40 as the upper normal limit of the ALT. But for the West, it is 19 and 30. Now, assessment of fibrosis. Whenever we see a patient with hepatitis B, we assess three things. One is ALT levels, one is the fibrosis, and DNA levels. So I'm just touching upon these aspects because these are required to understand the treatment protocols. So significant fibrosis, this is a FIB4 score. This is an online score based on age, AST, and ALT. If it is more than 1.5, the patient has significant fibrosis. This patient requires, if the patient has elevated DNA or elevated ALTs, this will require treatment. For cirrhosis, the INASL guidelines says 2.67 while the EASL says 3.25. There is some differences over there, but for anything more than 1.45 will probably require treatment. APRI score, that is AST to platelet ratio, again an online calculator can be done easily. If you do not have fibroscan, these can be used in your clinics regularly. You just need to have age, AST, platelet count, and ALT. If it is more than 0.5, we say it is significant fibrosis. If it is more than 1, INASL says 5 cirrhosis, while EASL says 1.5. So basically, understanding these cutoffs will help us understand whether the patient requires treatment or not. If you do not have the next machine, which is called as fibroscan. This is the one which we are routinely using in India, although not so economical, I would say, but it actually helps us understand what is the amount of fibrosis in the liver and will help us guide the treatment for these patients. For especially in concerning with hepatitis B, we say if the LSM, liver stiffness measurement, LSM is more than 7, we say there is significant fibrosis, F2 to F3. If it is more than 8, it is F3 fibrosis. More than 11 is considered cirrhosis. These are the individuals who will require treatment. If you do not have this, you can use APRI and FIB4 testing for this patient. This is a simple probe. It takes around 2 to 3 minutes for the assessment. The patient has to lie down comfortably after 3 to 4 hours of empty fasting. On his taking his right hand below the head. If he lies down for 2 minutes, the fibroscan will give us the amount of fat in the liver as well as the fibrosis in the liver. But some things to know, if the patient has elevated ALT levels, the fibroscan will be falsely elevated. If you have an obese individual, you need an Excel probe, otherwise the fibroscan will not be giving the proper measurements. And the patient should not have any evidence of cholestasis, that is high bilirubin levels, heart failure, other causes of congestive liver failure, or ascites where we cannot do fibroscan, or continued alcohol consumption where the fibroscan will be usually elevated. This is how we use fibroscan. These are the practical points which we should know. High bilirubin, high AST, ALT. Please do not do any fibroscan. It doesn't add anything to your treatment aspect. What is the goal of treatment in patient with hepatitis B? It is basically to improve the survival and quality of life by preventing disease progression in HCC and prevent mother to child transmission for pregnant women, prevent reactivation, and also probably treat the extrahepatic manifestations. We usually see that patients who are not started treatment early on, if the patient had viremia and has missed the medications, they tend to develop renal involvement later on, either in the form of MGN or MPGN later on. For patients with hepatitis B, the main endpoint is always long-term suppression of HBV DNA. But if you have HBsAg positive, if you can change, this is the best endpoint which we can achieve, loss of HBsAg with development of anti-HBs. If not, at least ALT normalization is achievable, that is biochemical response. But if an individual is E antigen positive, loss of E antigen is sufficient and development of anti-HB is sufficient enough for our patients. So goal is to achieve HbA1c loss, usually not possible. ALT normalization, yes, possible. E loss is possible, but DNA suppression is also possible. But it is very difficult to achieve this functional cure. What is functional cure? Basically, as a hepatologist and gastroenterologist, you want the patient that the functional cure that is defined as a sustained, undetectable circulating HbA1c levels and DNA. So the patient has no HbA1c and DNA. After treatment, the patient is said to have HbA1c functional cure. What is the advantage? If you have HbA1c zero clearance, which is achieved in hardly around 2% of patients, the risk of HCC is only 0.5%, which is as good as any normal individual. If you cannot achieve viral suppression, which is seen around 11%, the risk of HCC is 4.4% for HCC at 5 years. At least if you can achieve viral suppression, which is possible in up to 86%, 3.5% is the risk of HCC. So we will reduce the risk of HCC if we can achieve HbA1c clearance. But this is not possible at all because we all know that once the HBV enters the hepatocytes, it remains there as a covalently closed circular DNA. Once it remains there, we still have the virion activity still going on, which is very difficult to stop this. Although there is one drug which has come now, which has been recently published in NEJM. So the persistence of CCC DNA and HBV DNA prevents us from achieving the functional cure. How to identification of this is based on 3 markers. One we use is quantitative HbA1c, which is quite a little easy for us, but it's not a robust marker. But these are the novel markers in 2026, the combination of HBV core related antigen, which is derived from the pre-core and core gene, and it detects the HB core antigen, HBeAg, and P22 core. It is a direct marker of CCC DNA, and it even is detectable when the patient has completely suppressed DNA. HBV RNA, I'm saying the reverse transcriptase pathway. If you have the serum HBV RNA, these are still in experimental. Japan has this and they have been using routinely for their monitoring of their patients, but it is not yet available in India. I am not aware of any centers doing this. This primarily represents the pre-genomic RNA. It is released like a virion, that is CCC DNA. It gets converted into virion-like particles and reflects the active CCC DNA. So if you have these markers positive, that means the patient still has CCC DNA and chance of reactivation is still there. So the value of these novel markers is to identify the residual CCC DNA activity. It can help us identify, if we can understand if the CCC DNA is very low, yes, we can stop the nuke therapy with the chance of virological relapse will be very, very low and the risk of HCC will be very, very low. So these are the emerging biomarkers that can bridge the gap between the suppression of the virus and the true functional cure which we want to achieve in these patients. Coming to treatment aspect, I will be just touching upon the 3 main guidelines, EASL and INASL and WHO. WHO is more simplified, which is sufficient for enough for everyone to understand. If a patient is HbA1c positive, he has advanced fibrosis, as I said before, based on the APRI test, FIB4 test or FibroScan, whatever is available for you, and the patient has positive DNA, then the patient requires treatment. In the absence of that, if the patient doesn't have DNA positivity, it is suggested to monitor. On the other hand, if the patient doesn't have advanced fibrosis cirrhosis, this is where most of our primary physicians will be taking care of our patients. If the DNA is more than 2000 and there is elevation in the ALT levels, or the patient has fibrosis, family history of hepatocellular carcinoma, other risk factors such as alcohol, chronic consumption of alcohol, diabetes has been considered as a major risk factor for HCC, extrahepatic manifestations, renal involvement, or the patient has some other hematological malignancies and is undergoing some form of treatment, then the patient requires treatment for hepatitis B. In the absence of this, the patient doesn't require any other treatment and needs just monitoring. So simple thing, fibrosis, if you can assess that, if most of our patients are not fibrotic when they present to us for the first time, especially the younger population, look for the DNA, look for the ALT levels. If it is elevated, start the treatment. Monitoring is this is little complex, but what we practice routinely in our clinical practice is basically checking their ALT levels every 6 months along with If the patient has fibrosis or cirrhosis, we do alpha-fetoprotein and ultrasonography. A simple measurement of ALT every 6 months would be sufficient. If possible, at least once a year DNA testing, because most of our patients are here E antigen negative, lesser DNA, then you require ALT. We do every 6 months along with DNA every 1 year. Quantitative assessment is not possible. We don't do that. Fibrosis every year. So this is what we follow in our clinical practice, although the guidelines vary everywhere. If you have patient of hepatitis B, 6 monthly ALT is must, DNA every year, and if possible, fibrosis every year. Fibrosis, as I said before, based on these scores, we can easily assess the fibrosis of these patients. This is a very simplified treatment guideline from WHO. I suppose everybody should have gone, must have gone through this treatment protocol. If a patient who has more than 12 years has significant fibrosis or cirrhosis, regardless of the DNA and ALT levels, the patient has to be treated with antivirals. Or if you have any fibrosis markers such as FPRI more than 0.5, elastography more than 7, the patient needs treatment. If not, if the patient doesn't have fibrosis or cirrhosis, the DNA is elevated more than 2000 and ALT is more than upper limit of normal for your lab, that is 40, and the patient needs treatment. In the absence of this, if the patient has any other co-infection, family history of liver cancer or cirrhosis, immunosuppression, this is very important. Diabetes and MASLD, this was not there previously, but they say that the risk of HCC increases. So the patient who has HbA positive, if you cannot do anything else, you can just start them on treatment if the patient has diabetes and MASLD. If somebody has glomerulonephritis or vasculitis, which is common feature of hepatitis B, the patient needs treatment. If you do not have any absence of access to HPV DNA assay at all, if the patient has elevated ALT levels, even then you can start the treatment. Treatment preferred, we usually use TAF or entecavir. If the patient has either of them or TDF. TAF is very simple and we have been using it very often. We only, as per now, the WHO says that if the DNA is very low and the ALT is normal, the individual does not have any other risk factors which are said over here, then you can defer the treatment. Most of our patients, actually, very few patients tend to fall here. If you follow this strictly, everybody should be treated for this hepatitis B. Surveillance for our patient with cirrhosis is for alpha-fetoprotein ultrasonography every 6 months, which we all follow. Every 12 months, treatment response based on the pre-test ALT levels and HBV DNA levels. If you are starting TAF, you usually tend to monitor the creatinine, and if you are starting TDF, you also monitor their DEXA scan to assess for osteoporosis. This is what I have said in the previous slide. One important thing which I'll be discussing again future is pregnant women who have DNA more than 2 lakh should be initiated on treatment. And as I said before, these are all the indications where we have to start irrespective of the stiffness or the ALT levels. For this is the age cutoff which has been added now, age more than 30 and DNA more than 2000. If you cannot assess stiffness or ALT, start the patient on treatment. That is what the guidelines are now recommending. INASL has slightly modified. It has not completely adapted this WHO guidelines, and they say that patients who have persistently elevated ALT on 2 occasions in 2 months, within a span of 6 months, then the and has a elevated DNA levels, those should be treated, and those patients should be treated. If a patient has chronic hepatitis B, HbA positive, irrespective of the DNA and ALT levels, should be treated if they have cirrhosis. So any patient with cirrhosis coming to has HbA positive, please treat the patient. Don't bother about anything else. If you cannot monitor, it's okay. We just want if the HbA is positive, patient has cirrhosis, treat the patient. All the patients who are HbA positive, who are concomitant other things which I discussed before, should again be treated. Here again we have added ALF and ACLF over here. These are the patients which we actually more often we think that we not require, but yes, if the bilirubin is rising, INR is rising, start the patient on treatment with antivirals. A similar thing which I said before, but what here is Again, this has been adapted in nasal as well, that is age above 30, elevated ALD, and evidence of significant fibrosis. The patient has to be treated for the immunotolerant phase also. Available drugs are very effective as of now. If you see entecavir, even in E antigen positive and E negative, where our major chunk are there, its HPV suppression is almost 100%. HbA loss is very low, that is less than 1%, but in E antigen positive, it is 38% at 10 years. TDF, again 99% chance that the patient will suppress the virus, but the loss of HbA is very low, that is 0%. Well, if the patient has E antigen positive, it ranges up to 10% and suppression up to 99% at 10 years. TAF, which we frequently use, suppression ranges up to 95% in negative, and HbA loss is 1.2%. These are very considered as they do not usually develop any resistance. None of the viruses are known to develop any resistance. Also, some genotypic assessment may be helpful, but rarely we require such kind of measurements. These are the responses. Simple ones which we use in clinical practice is the biochemical response, that is normalization of ALT. If the patient has persistent normal ALT, we consider it as biochemical response. Serological, we want to achieve that E antigen loss in E antigen positive patients, HbA loss with HbA positive patient, which is very, very rare. As I said before, 1% of the individuals respond in such a way. Histological, there should be decrease in the inflammatory activity without worsening of the fibrosis. Virological on treatment and off treatment is different. So this is off treatment, basically less than 2000 at 12 for 12 months after the end of therapy. That is when we actually plan to stop the antivirals. On response, basically DNA less than 10 is considered as complete response. These are variable things, probably not very much relevant for our clinical practice, but yes, if the patient has no loss of DNA at 3 months, less than 1 log decrease, he is considered as non-response. The patient has to be tested for resistance, or the patient has to be checked for adherence and other concomitant problems or addictions. Stopping is a major problem. We believe that most of our patients, actually all our physicians, we also consider that most of these patients require lifelong therapy. The therapies are very safe and excellent and effective, but the problem is the adherence to these lifelong therapies, which they are okay to be cost, not that heavy costed. They cost around 1200 rupees per month. We can only discontinue in selected. This is where our major chunk of patients is. What we do is we check DNA every 6 months after 3 to 4 years of therapy. If the DNA is negative 3 times after 3 to 4 years of therapy, and the patient agrees to undergo regular testing, we stop the therapy. Unless and until they agree, we do not stop the therapy. In E antigen positive patients without cirrhosis who achieve E antigen seroconversion and a completely undetectable DNA for 12 months after consolidation therapy, they can be stopped. Definitely, if the patient has HbA loss, which usually occurs in acute settings, acute viral hepatitis, we actually stop the therapy. But American Association says that these therapies should be indefinite for adults with E antigen negative, immune reactive chronic hepatitis B, unless there is a compelling rationale for treatment discontinuation. This is what ASLD guidelines suggest. This is the EASL guidelines. If I have to stop a therapy, I check for DNA every 6 months for 3 consecutive times after 3 to 4 years of therapy. Then also we are doing quantitative HbA, again a marker of cccDNA. If it is less than 100, definite chance that the patient will not have reactivation, the cccDNA is completely suppressed, we stop the therapy. But some suggest that even if it is less than 1000, you can stop the therapy because it predicts the chance of seroclearance is very high and the reversion is very, very rare. If you have the possibility of assessing QHbA, quantitative HbA, it costs around 2,500 rupees. You can plan to stop the therapy. If you have a reference from your hematological colleagues who say that I'm starting some of, or the oncological colleagues that I'm starting some of these therapies for cancer, those patients have to be tested for hepatitis B surface antigen, core antibody, and DNA. Please do this test. Even if you don't want to DNA, just check the core antigen and surface antigen. Any of that is positive, start these patients on antivirals, prevent the reactivation of virus. Rituximab, a drug which is very well known to increase the chance of reactivation, Those patients need lifelong therapy for at least till the completion of therapy and at least 1.5 years after the cessation of therapy. This is what is written over here. Non-Hodgkin's lymphoma, the patient has to be tested and the patient is planned for rituximab, continue at least 18 months after stopping of the rituximab. In CKD, there is some dose modification which will be available online. This is one of our publications where we noted that CKD prevalence in HBV patients is around 8%. They may develop all kinds of renal involvement. The treatment remains almost the same, but the dose has to be modified. TAF, there is no adjustment till the GFR is less than 15 ml, which is what we prefer. Entecavir in TDF has to be modified based on the GFR, and the patient is on dialysis. The patient has to take these medications, entecavir and TDF, after every dialysis or every 7 days. Pregnancy, as I said before, if the DNA is more than 2 lakhs, start the therapy at 24 to 32 weeks. Continue at least till the 12 weeks after the delivery. The individual can continue breastfeeding. There is no harm in breastfeeding the next kin or kid, next baby. But the patient has to be monitored regularly even after pregnancy. And if you have a patient who is pregnant, ensure that the newborn is given the vaccination along with the anti-HPS loading within 72 hours. That is 0.06 ml per kg. This is what is the hepatitis B, and this is very important for us. If you are a doctor or you have some colleague who is a doctor, who is a physician or a nursing staff, and they have hepatitis B, easily recommends even if the DNA is more than 200, the patient has, that doctor or the healthcare worker should be treated for hepatitis B. While CDC says if the DNA is more than 1000, prohibit that person from doing any exposure-prone procedures, like if an individual is doing dental procedures or some surgeries, till the DNA comes down below to 1000. So anybody more than 200, that doctor or that healthcare individual has to be started on treatment. The routine rules does not apply over here. That's the reason I'm just emphasizing again and again. For HBV and HIV, irrespective of the CD4 count, we have to start them on ART. These are the 2 of the 3 drugs should be there. We usually start them on Viropil or some other combination. And these are the recommended drugs which we use for these patients: dolutegravir, emtricitabine or lamivudine, or TDF or TAF. This is the combination what we prefer to use for our patients. HCV infection and HBV is quite rare. It is around 0.7 to 5.8%. But if you have hepatitis B and C both positive and the patient requires HCV therapy, the patient should initially start on HBsAg, because HCV, the core of HCV, inhibits HBV DNA. So once the patient you treat with HCV, there is high chance that the patient may have hepatitis B reactivation. So start the patient on hepatitis B treatment 2 weeks before, then start the HCV therapy. As I said before, patients who have diabetes and mast cell should be started on treatment. Coming to the last 2 slides, these are the newer drugs which are come, and GSK has announced a favorable result with this. This was the NEGM study where they had given bepirovirsen. It is basically a HPV RNA. It is antisense oligonucleotide or ESO. It is short single-stranded nucleotides and targets the mRNA levels rather than the DNA. The primary endpoint was achieving negative HBsAg and DNA, and bepirovirsen 300 mg was able to do that. For 24 weeks, it resulted in 10% loss of HBsAg and HBV DNA at 6 months. So the combination of bepirovirsen and pegylated interferon has been assessed, and they say that when you add this, the chance of HBsAg clearance is almost 15%. So if you have 100 patients, 15 patients may clear the virus, may completely achieve functional cure, which is now only 1% as of now. To summarize, HBV continues to be a major concern in India, especially in the regions we stay. One-time diagnosis, yes, if you do HBsAg once, that is sufficient, but it is a lifelong strategy. You must follow these patients regularly. Ensure that the family is screened for hepatitis B. If possible, please vaccinate them at the earliest. If a mother is positive, vaccinate the newborn as soon as possible. Treatment is based on 3 things: E antigen, ALT levels, and DNA levels. It appears to be confusing, but if you go through the WHO guidelines, it is very, very simplified, and they have made it very simple for understanding of all the physicians. China and some other guidelines suggest that a positive HPSAG is sufficient to start the treatment if you don't have any access to assessment of DNA or any other things. Although not probably not very financially viable for Indian population, but yes, one of the things which WHO may come up to achieve the eradication of hepatitis B. Special situations which I mentioned, like pregnancy, CKD, and healthcare workers require special attention. Thank you. I'd be happy to take any other questions.
Thank you very much, sir. I think this was one of the most exciting presentation and updated one. So I just forgot that we have also got Dr. Barsa Agarwal, sage at the Jalan Hospital, Asian Jalan Hospital at the Dhanbad, and Dr. Akash Singh is here from the Baroda. He's our co-host today also. So initially, Dr. Narayan Agarwal, can you give the initial comments on this talk?
Yeah, definitely. I have one or two questions to Dr. Anand.
Yes, sir. Please.
Yeah.
Actually, sometimes actually the patient lost to follow-up and they stop the treatment, and then again they are coming with some problem. What to do then?
Sir, if the patient has lost the follow-up and if he comes to you, if possible, continue to HPSAG can be beneficial, or else at least one ALT levels. And if the patient continues to have HPSAG positive, better to start the treatment. If he is already on treatment, you can continue the treatment, sir.
Dr. Sanjay Shah, sir, unmute yourself.
Excellent, Dr. Anand. Very well explained everything in such a short time. I think we've covered most of the things. What I would like to ask is, we have a huge burden of pre-diabetes. Are there any guidelines for pre-diabetic patients with hepatitis B positive?
No, sir. As of now, diabetics are considered as eligible patients for treatment, not pre-diabetics as such.
And do we wait for the blood glucose to be controlled, or we start treatment straight away?
We can start the treatment immediately,
Right.
sir.
Right. And what about
Yeah, Dr. Varsa.
Thank you so much, sir.
immunotherapeutics? Dr. Anand, what about
Yeah,
immunotherapeutics?
Dr. Your comments. Yeah.
So, sir, Dr. Shah, please, sir, I couldn't hear you.
Yeah, sir.
Yeah, I was
Dr.
asking
Sanjay
about
Shah, sir.
Yeah, I was asking about immunotherapeutics. Any role of those?
Sir, as of now, immunotherapeutics for hepatitis B, sir,
Yeah.
I think they are still in research areas. They are not yet come to the market. The research is, I mean, after the introduction of this antisense oligonucleotides, I think everybody has now shifted to bepirovirsen. Immunotherapeutics, they have been tried for hepatitis C and hepatitis B, but HCV we have almost eradicated. Hepatitis B, I think the data is still in the research areas and not at in clinical area.
Right. Thank you. Thank you.
Yeah, Dr. Barsa, your initial comment.
Thank you so much, sir. Thank you so much. That was extremely informative and crisp, because I understand that explaining hepatitis B, which is already having multiple guidelines in such a short time, I think that was extremely informative and crisp and comprehensive. Thank you so much, sir. And also I would like to just take 2 minutes to express my gratitude to be able to be a part of such eminent members, physicians and gastroenterologists. One question, sir, if suppose the patient is having HBe antigen negative, does that have any kind of impact on the prognosis of hepatitis B, chronic hepatitis B, in comparison to those with HBe antigen positive patient, and especially if suppose HBe negative is there with a very low viral load? So can we say that the patient will be having a better response to the treatment, or a better freedom from fibrosis or other complications?
That's an excellent question. Most of our patients actually fall in this category, and they do not progress to HCC or cirrhosis or fibrosis. So we can safely say that probably they do not require treatment, but the current guidelines have modified it. They say that if the DNA is more than 2000 and age is 30 years, just start the treatment. Don't worry about ALT levels.
Yeah,
And
fine,
sir,
sir.
why is there so much of disparity between American guidelines and European guidelines? It is just because of the population related?
Their prevalence is pretty low. If you see the Taiwan guidelines, Japanese guidelines, Chinese guidelines, they have made it very, very simple. They say just HbCG positivity, start the treatment. That is what WHO will adopt in the next time, probably because 2030 was the target. We probably cannot achieve 2030 eradication. We may have to
Yes,
wait
sir.
2 more years.
One more
Thank
question
you.
to Dr. Aran
Yes, sir.
regarding the acute severe hepatitis. The patients who comes with the acute features of acute severe hepatitis, HbsAg positive, E antigen positive, and DNA is also very high. Whether you would like to start the treatment straight away or you can wait.
So basically, we fear the risk of liver failure and then ending up in transplant. So I usually start the antivirals immediately. If the ALT, AST levels are more than 5 times, bilirubin more than 3 to 5, I start the treatment, sir. We can stop the treatment later on. We have stopped for almost 20 to 50, 25 patients. I have stopped the treatment after 6 months, but it will prevent acute liver failures and the morbidity associated with high jaundice.
Yeah, definitely. Agree with you.
I think this was a very vital point. So, Dr. Mohsin, can you see some chat box and question from the audience?
Yes,
Dr. Mohsin?
there are five
If it
questions.
is admin, not yeah.
So one question is, which 2026 update in HBV risk stratification most reliable to identify patients who need immediate antiviral therapy despite normal ALT levels?
I think if the patient has normal ALT levels and has family history of any malignancies or hepatocellular carcinomas, so that is when we start them on treatment. Or if the patient has concomitant diabetes or MASLD, we start treatment even if the ALT is normal. And these are one or two criteria. And if the patient is planned for any of the immunosuppressive medications like corticosteroid for more than 4 weeks, that patient requires treatment.
So the second question is, in 2026, how should we optimally integrate non-invasive fibrosis tools like FIB4, ELF with HBV DNA to guide timing of treatment and referral?
So, ELF actually is a very good test, but it is validated for patients with fatty liver, MASLD, not it for hepatitis B. And the cost approximately 6 to 7,000, not viable for every center. We usually do FIB4 testing and fibroscan. If the
Oh,
fibroscan is more than 7 and the patient has normal ALT, then that patient requires treatment. If the fibroscan LSM is more than 9 and the ALT is elevated, that individual requires treatment.
okay. The third question is, what are the current clinical scenarios where TAF or entecavir is clearly preferred over older agents in preventing cirrhosis and HCC?
As of now, there are multiple studies done on this aspect. Each time they keep changing. The TAF is better, entecavir is better, but all these drugs are actually equally effective. We have been using TAF and we find it very effective, and the side effects are very, very minimal with this drug. So only thing where we prefer it this is elderly patients age more than previously we used to use TDF. That is when the guidelines came that elderly patients, those who have bone disease or chronic kidney disease, start them on TAF or entecavir. But now universally we are using these drugs.
So are we seeing any resistance with TAF?
As of now, I have not documented any resistance. There are only few case reports which have been reported.
Suppose, sir, patients who are on TAF and they lost to follow-up. After few years, they come up and they discontinue treatment. So shall we start again with TAF or look for any resistance?
No, I don't think we see any resistance. That's what Sir also asked initially, Dr. Agarwal, sir, that if a patient has discontinued treatment and has come after a few years, we usually check his ALT levels, HbACG, because there is spontaneous seroconversion also, which has been seroclearance, which has been reported. If the HbACG positive, ALT can be done, then we usually continue the treatment.
So the next question is, which HBV patient profiles in 2026 mandate early referral for transplant or specialized hepatology care even before over decompensation?
Hepatitis B with HCC is one exception where the patient requires transplant if the patient has been identified early on. These are the patients or patients who have persistently, they progress into acute or chronic liver failure where the bilirubin persistently remains high, not responding, and INR remains high. That is when we suggest transplant.
Okay. I think we have discussed already. How should HBV management be modified in special populations in 2026? That is diabetics, MASLD, CKD, pregnancy, and immunosuppressed patients. I think this.
Yeah, that discussed already, I think. So, one more question by Dr. Barsa.
So,
Yes, sir. Sir, I wanted to know if
In case,
suppose the count of DNA is more than 2 lakh, irrespective of the trimester of pregnant women, can we start, or depending upon the ALT, ST level and the fibrosis, we will start from 28 to 32 weeks?
So if the DNA is more than 2 lakhs, 24 to 28 weeks is the suggested treatment option. But there are few studies where they say that if the patient is already on treatment, just continue TDF instead of TAF. So you can start anytime, any trimester. If you are worried that first trimester में क्या होगा, start the treatment with TDF. That's okay for the baby.
Okay, thank you so much, sir.
yeah, that we have, yeah, so we have got Dr. Noni Ji Singh, a very eminent physician from the Dibrugarh. So, Dr. Noni, one problem which I find that although boosters have been advocated, how many doctors in your area have taken booster for the hepatitis B vaccination?
Actually, it is very difficult question, sir, because our doctors are least bothered about this immune status. Actually, yeah, and hardly if I advise my patient to go for anti-HBs, antibody titer, for the revaccination or not. If doctors comes, they've been advised and they have been asked to do the anti-HBs test, they hardly do the test actually. And to know the immune status, to know the 10 IU is the standard level. And I don't think the people or doctors very much oriented regarding this.
Yeah, Akash, any comment on that? Dr. Akash?
You are mute.
Yeah. Dr. Akash, unmute yourself.
Pertaining to your question, which you asked to Dr. Jaisingha, he said very correctly that doctors hardly are taking the booster doses and all, and hardly testing the titers, antibody titers. But what they are doing is that suppose they are exposed, then there is a panic reaction, and then they are taking this booster dose. Otherwise, as per the advice and as per the periodicity of the booster dose, they are not taking.
Akash, I think if you take after exposure some booster dose, will it work immediately?
No, we have to give immunoglobulins first, no? But that some are taking, some are not taking.
Or any immunoglobulin therapy there for that?
It is there.
Yeah. So,
can I ask a question to the sir?
yeah.
Just I'd like to ask that my question is that if sometime the hepatitis itself can cause the vasculitis or MPGN, or maybe something autoimmune disease with the hepatitis, and they have to be on the steroid. How to approach this type of patient? Number one. And the number two, is there a need to do the genotype of hepatitis B that will be responding with the mix for having the CLD or Hep C, HCC?
So there is no role of doing genotyping testing for hepatitis B or hepatitis C. We do not do any genotyping. It doesn't matter for us. Sorry, I missed the first question because there are some technical.
Yeah. Dr. Noni, you are not audible. Repeat your question.
No. The associated with vasculitis, maybe vasculitis with Hep B or even Hep B associated vasculitis or MPGN who are invariably need the steroids. How to approach this type of patient?
Those patients have to be started on treatment, sir, irrespective of the DNA levels. Especially if cryoglobulinemia is one of the features of hepatitis B, so we actually think that it might be virus related. Them on treatment.
What about the dose of the steroid? Like we should go for the something level of the steroid can be prescribed safely, or there is a limit of the steroid.
There is no limit as such, but if you are giving high dose more than 40 milligrams or at least 40 milligrams, you should start the antivirals 2 weeks before the initiation of immunosuppression.
So Dr. Mohsin, I think we have discussed this scenario very well. So Dr. Akash, can you ask for the take-home messages from each of our moderators, and then Dr. Barsa will be concluding the whole scenario. Yeah, Akash.
I request Dr. Anand Kulkarni to give a final take-home message of the entire talk for the audience.
Thank you so much, sir. My take-home message would be, first of all, vaccinate yourself. As a doctors, we should protect ourselves. And when you identify any patient with hepatitis B, treatment is secondary. Please vaccinate the family at least and screen them for hepatitis B.
Great.
Doctor,
My comment for Dr. Anand is definitely I will congratulate. I would like to congratulate Dr. Anand for his excellent talk, very crispy and very informative talk. He is very clear about the indications and when to start and when not to start. Congratulations again.
Thank you, sir.
And I would like to add one thing finally,
Yeah.
that about 15, 20 years back, we vaccinated about 3,000 people in one day, free of cost, in Anandmi Ashram in Haridwar. And we had a 90+% of repeat vaccination after 1 month and 6 months. We completed the 3 doses that time, and it was all free of cost, long time back.
Great. So, yeah. So, any
One
take
more
home
thing
message?
for sir, for encasing sir, for one more thing, you have organized this CME. Definitely, I will like to congratulate you also. But I want a few more CME in a recent future, I think.
Sure, sure, sure. So,
Dr.
yeah,
Mohsin.
so Dr. Mohsin, your final take home message?
Yeah, I agree with Dr. Anand, sir. We should vaccinate everyone, and particularly we healthcare professionals should take boosters and measure titers. If titers are low, we have to again take booster doses.
I
Yeah,
also
so
request
I think it's
Dr. Noni to give a final take-home message.
No, it was very nice and very concise and to the point. It's such a simplified talk, easy to understand for everyone, and it is very nice. And so many new things are there, and really is nice attending this. And I'd request we should talk on autoimmune hepatitis also sometime because it is
yeah,
the
sure,
least.
sure.
Thank you.
Sure. So I think Akash, now before you propose the vote of thanks, Dr. Varsa, can you give the your take home message and conclude this talk?
Yes. So before that, again, I would like to thank Anand sir because the way he has mentioned everything in such a crisp way, in a concise way, because hepatitis B is not only vast, there are so many guidelines that ultimately we all land up in confusion. Which guideline has to be followed? What are the way by which we can deal the patient? By the way, he has mentioned about the basic goals of treatment. It is not only reducing the suppression, but also the long-term complications such as cirrhosis and ultimately the chances of malignancy, that is HCC, which can be preventable just by treating hepatitis B. The screening of hepatitis B, preventing mother-to-child transmission. These are some of the important aspects, and also screening all the patients of dialysis, adjusting the doses, and also trying to deal the cases wherein we find HCV, concomitant infection of HCV, and the transplant patient, how we need to deal with hepatitis B in such cases. Plus, the patients who are about to be started on immunosuppressive, many a times we miss understanding the importance of starting with the antivirals in these patients. So I think that was extremely informative. Even though I have been trying to study hepatitis B, I think today's presentation was so informative and it was so helpful. I am extremely thankful to everyone, to Anand sir and NK sir for giving me this opportunity and for being part of such informative CME.
Thank you, Varsa. So
Thank you very
Dr.
much, Dr.
Akash.
Vaishnav. I profusely thank Dr. Anand Kulkarni for such a elaborate and lucid talk and very, very well explained every aspect of hepatitis B management. And I think all the audience who are here, majority of them being physicians, should be in a position to treat this infection, which is so rampant, after hearing to his talk. I also thank Dr. Narayan Agrawal, Dr. Mohsin, and Dr. Sanjay Shah for moderating the session so well. for asking so many questions, carrying the discussion forward, and making the talk more relevant to the audience. I thank Dr. Nori Jaisingha, who is for being present with us on this podium and for also giving his valuable comments. I thank Dr. Mohsin for coordinating the entire show, arranging the talk, and he is always with us for all of our academic endeavors. I thank Dr. Vaishya for being here and for giving her comments, especially the final comments, which are so relevant. I thank profusely all the doctors who attended this webinar and who keep on attending this regular webinar, who are in large numbers, and their questions always encourage us to come up with more and more topics and more webinars which are based on latest medical education. I thank the USV for providing the digital platform for conducting this talk, and they always have helped us by providing this platform, which are so seamless and so well organized that we never had any technical hitch. I now hand over the session to Dr. Aishi to finally conclude the session.
Thank you. Thank you so much, Dr. Akash Singh, sir. It's my pleasure to conclude the session and provide the vote of thanks. Thank you so much, Dr. N.K. Singh, sir, for bringing us one another episode of CME India. Thank you so much to our speaker, Dr. Anand Kulkarni, sir. Thank you so much, Dr. Naran Agrawal, sir, Dr. Sanjay Shah, sir, Dr. Noni, sir, Dr. Akash Singh, sir, Dr. Mohsin, sir, and Dr. Varsha, ma'am, for being there with us. Thank you so much, tech team, and all the delegates who have been there with us for making the session so successful. Thank you so much. Looking forward to see you again.
Good night to you all. Good
Yeah.
night.
Thank you. Good night.
So,
Thank you so much.
thank you. Thank you very much.
Good. Thank you so much, sir.